Chapter 36, Antihistamines, Decongestants, and Antitussives, and Expectorants. Understanding the common cold, most caused by viral infection, so rhinovirus or influenza virus. Virus invades tissues, the mucosa of the upper respiratory tract, causing upper respiratory infection. Excessive mucus production results from the inflammatory response to this invasion. Fluid drips down the pharynx into the esophagus and lower respiratory tract, causing cold symptoms, sore throat, coughing, and upset stomach. Irritation of the nasal mucosa often triggers the sneeze reflex. Mucosal irritation also causes release of several inflammatory and vasoactive substances, dilating small blood vessels in the nasal sinuses and causing nasal congestion. Treatment of the common cold. It's difficult to identify whether the cause is viral or bacterial. Treatment is empiric therapy, treating the most likely cause. Antivirals and antibiotics may be used, but a definitive viral or bacterial cause may not be easily identified. Supplements and herbal products that happen to help with the common cold prevention are vitamin C, Echinacea, and gold seal. Antihistamines are drugs that directly compete with histamine for specific receptor sites. So you have two histamine receptors. You have your H1 and H1 and H2. In anaphylaxis, what is anaphylaxis? It's a severe allergic reaction. The release of excessive amounts of histamine can lead to constriction of smooth muscle, especially in the stomach and lungs, increase in body secretions, vasodilation and increased capillary permeability, movement of fluid out of the blood vessels and into the tissues, and drop in blood pressure and edema. Histamine is a major inflammatory mediator in many allergic disorders. You have allergic rhinitis, hay fever and mold, dust allergies, anaphylaxis, angioedema, drug fevers, insect bite reactions, and urticaria. Antihistamines and histamine antagonists. So you have H1 antagonists, also called H1 blockers. Examples include Allegra, Claritin, Zyrtec, Benadryl. Those are all they should be very familiar to you. Antihistamines have several properties. They have an antihistaminic, an anticholinergic, and a sedative effect. The mechanism of action is the binding of the H1 blocker to the histamine receptors. It prevents the adverse consequences of histamine stimulation. So you'll see vasodilation, increased GI and respiratory secretions, and increased capillary permeability. Antihistamines, we will use them in management of nasal allergies, seasonal or perennial allergic rhinitis, so hay fever, allergic reactions, motion sickness, Parkinson's disease, and sleep disorders. Contraindications include very important. Remember, narrow angle glaucoma, cardiac disease, hypertension, kidney disease, peptic ulcer disease, seizure disorders, BPH, which stands for benign prostatic hyperplasia, and pregnancy. Adverse effects include anticholinergic effects. Most common include dry mouth, difficulty urinating, constipation, and changes in vision. Drowsiness, you might have mild drowsiness to deep sleep. Non-sedating, peripheral acting antihistamines developed to eliminate unwanted adverse effects, mainly sedation. They do work peripherally to block the actions of the histamine, thus fewer central nervous system adverse effects. Longer duration of action, it increases compliance. So some examples of those are Allegra, Claritin, and Zyrtec. Traditional antihistamines are older. They work both peripherally and centrally. They have anticholinergic effects, making them more effective than non-sedating drugs in some cases. Examples include the medications listed below here. Nursing implications to antihistamines. So these are your teaching points. You want to instruct patients to report excessive sedation, confusion, or hypotension. Instruct patients to avoid driving or operating heavy machinery. Advise against consuming alcohol and other CNS depressants. Instruct patients not to take these medications with other prescribed or over-the-counter medications without checking with their prescribers. Nasal congestion, excessive nasal secretions, inflamed and swollen nasal mucosa. Primary causes include allergies and URIs, or the common cold. So that's upper respiratory infections. Oral decongestants. There's two dosage forms. We have oral, or inhaled or topically applied to the nasal membranes. Prolonged decongestant effects, but delayed onset. Effect less potent than topical. No rebound congestion. An example would be Sudafed. Topical nasal decongestions include topical adrenergics. They have a prompt onset, they are potent, and they are sustained use over several days. Causes rebound congestion, making the condition worse. Remember that. Epinephrine, oxymetazoline are very common forms of that. Inhaled intranasal steroids and anticholinergic drugs, often used prophylactically to prevent nasal congestion in patients with chronic upper respiratory tract symptoms. They are not associated with rebound congestion. Intranasal steroids, such as Rhinocort, that's a popular, and Flonase is very popular right now as well. Those are some examples of those. Then you have an intranasal anticholinergic like Atrovent. Contraindications, once again, for these nasal decongestions. Remember this: narrow angle glaucoma, uncontrolled cardiovascular disease or hypertension, diabetes and hyperthyroidism, inability to close eyes, history of a CVA or TIA. What are those? Strokes, long-standing asthma, or once again BPH. Nasal decongestion adverse effects. So in the adrenergic section, you will see nervousness, insomnia, palpitations, and tremors. And under the steroids, you'll see local mucosal dryness and irritation. Implications for the nasal decongestions. So this is what we would teach our patients. Once again, when we get to implications, this is our patient teaching. Patients should avoid caffeine and caffeine-containing products. Patients should report a fever, cough, or other symptoms lasting longer than 1 week. Monitor for intended therapeutic effects. Now let's talk about cough physiology. Respiratory secretions and foreign objects are naturally removed by the cough reflex. It induces coughing and expectoration, initiated by irritation of sensory receptors in the respiratory tract. Antitussives are drugs used to stop or reduce coughing. So we'll use opioid or non-opioids. Used only for non-productive coughs. Most of the time, coughing is beneficial. Why? Because it removes excessive secretions, it removes potentially harmful foreign substances. So coughing is not necessarily bad. In some situations, coughing can be harmful though, such as after a hernia repair. The mechanism of action for opioids, it's going to be suppress the cough reflex by direct action on the cough center in the medulla. Remember that. Any of these slides that have the red highlighted text you want to remember. Analgesia, drying effect on the mucosa of the respiratory tract, increased viscosity of the respiratory secretions, reduction of runny nose and postnasal drip. Examples include codeine and hydrocodone. Have you ever heard of codeine 3 cough syrup? We oftentimes will use that. For non-opioids, the benzonatate is going to be used to suppress the cough reflex by numbing the stretch receptors in the respiratory tract and prevent reflex stimulation of the medullary cough center. And then our dextromethorphan works like an opioid, not an opioid, an opioid. It has no analgesic properties, no CNS depression. So adverse effects of our benzonatate is dizziness, headache, sedation, nausea, and others. Dextromethorphan is dizziness, drowsiness, and nausea, and opioids is going to be sedation, nausea, vomiting, lightheadedness, and constipation. Antitussives, the implications, we want to perform respiratory and cough assessments and assess for allergies. Instruct patients to avoid driving or operating heavy equipment because of possible sedation, drowsiness, and dizziness. Report any of the following symptoms to the caregiver. Cough that lasts more than 1 week, persistent headache, fever, or rash. Antitussive drugs are for non-productive coughs. Monitor for intended therapeutic effects. Make sure you remember antitussive drugs are for non-productive coughs. Now, what are we going to give for productive coughs? Let's talk about expectorants. Drugs that aid in the expiration or the removal of mucus. It's going to reduce the viscosity of secretions, disintegrate and thin secretions. An example is guaifenesin. Mechanisms of action. The reflex stimulation drugs cause irritation of the GI tract, loosening and thinning of the respiratory tract secretions occur in response to this irritation. Direct stimulation, the secretory glands are stimulated directly to increase their production of respiratory tract fluids. The final result, thinner mucus that is easier to remove. By loosening and thinning sputum and bronchial secretions, the tendency to cough is indirectly diminished. Expectorants should be used with caution in older adults and patients with asthma or respiratory insufficiency. Patients taking expectorants should receive more fluids, if permitted, to help loosen and liquefy secretions. Very, very, very important. Report a fever, cough, or other symptoms lasting longer than 1 week. Monitor for intended therapeutic effects. Now, some herbal products like Echinacea. It reduces symptoms of the common cold and recovery time. Adverse effects include dermatitis, GI disturbance, dizziness, and